Good afternoon, everyone, and thank you for joining us today for our third progress update, sharing strategies, successes, and secrets. My name is Michael Cinque. I run pharmacy for Genesis Healthcare, and we have a really good webinar for you today. We're looking forward to sharing, and we're looking forward to your sharing back. As a reminder, the D2D mission, is a 25% reduction of scheduled medications in long stay patients. And so we just want to remind you, that's no small goal, but we're shooting high, and we believe we're going to make an impact here together as we work together to improve the care of our patients. What we'll be doing is helping to provide with tools, support, and what you'll be doing is providing the community feedback to help us all learn. We are facilitators, but you do as much teaching as we do. So we're in this together, and so far it's going well. So what have we done to date? We've had webinar lectures on building your Deprescribing team, how to identify champions and stakeholders, how to develop your Deprescribing intervention and process, with some data to show how to do that, some journal articles. We've worked on some categories of medications where we've reviewed Deprescribing algorithms, proton pump inhibitors, vitamins, anti-hyperglycemics, and the last one on optimizing anticholinergics I thought was particularly interesting. And finally, we presented a Deprescribing communication techniques. That's the FRAME acronym, the FRAME process. So these are the things we've done. What we do here is we talk about what are we doing. So where every other month we have a more didactic webinar and then a more interactive webinar. This is the interactive webinar. So participation is encouraged. Please participate. Use the chat function during the formal presentation, and then when you have something to say, feel free to unmute yourself. This session is being recorded. Slides will be available for you to review later. I know many people have told us that that's valuable. So here we go. Our objectives for today is we're going to discuss the role of nurse practitioner team members and identify optimal ways to collaborate to deprescribe. So this will be a focus on collaboration. Identify some successful strategies for deprescribing, some common barriers, and then once we get through that piece, we're going to describe an opportunity to participate in Deprescribing Office Hours, where you'll have a chance to get some one-on-one help. And that's going to be very exciting, and we hope you'll find that interesting. So today, we're doing presenters from the field. And today we have Tony Clark, who's a nurse practitioner at the McKinley Center at Red Rock Center in New Mexico. We may get Dr. David Greenberg, who's the medical director at McKinley Center. He was ready to come, and then, as many of you know, he got pulled away at the last minute. So Dr. David Greenberg may or may not join us today. And we have Teal Hutzler, who's a nurse practitioner from the Care Haven Center in West Virginia. So Tony and Teal, welcome. And Tony, I wanted to start with you. How did you get started with deprescribing in your center?
Well, it started with, when I first arrived, I met my medical director, Dr. Greenberg, and we had different discussions about different things. And he mentioned that he let the CNEs know that any PRN medications that the patients haven't taken in the last 60 days to DC them. And I said, I'd like to take on that role. And he said, no, that's okay. I mean, no, I want to look in the charts and see what these patients are on. and what they haven't been taking. And I just went from there, and just on my monthly visits, I just go in there, make a list of all their PRN medications, and go in there more and just look and see, hey, you haven't taken this in 60 days. Out. Let's
Good.
go. Yeah.
That's awesome. Have you so the PRN meds are a target
Yes.
because they get put on, and then what happens is when they're there forever, if the symptom comes back, it doesn't always get reassessed, does it?
Exactly. No one
Right.
tells anyone. So you just, no one knows.
That's right. That's awesome. How about with scheduled meds? Have you had any success at your center deprescribing with the scheduled medications?
Actually, yes, I have. Namely, the one that comes to mind is levothyroxine.
Mm.
And I get that from my doctor that I used to work with in Houston. You know, he will slowly cut down, and I just use that tactic. I check their thyroid function and see, hey, can we slowly cut down until eventually it goes away? So another one is insulin. When I arrived here, no one was on metformin, and I thought everyone had, crappy kidney function. But no, it turns out the kidneys are okay. So I actually managed to wean off insulins and just bring them onto oral hypoglycemics. So yeah.
That's beautiful.
Mhm.
Do you see much, sliding scales in your center?
Oh man. Oh wow. When I first arrived, it seemed like every single patient, resident was on a sliding scale, and it drove me crazy. I'm like, this is not evidence-based. Why is everyone on a sliding scale? And my mantra is sliding scales, they're the devil. Just, that's just it. And it was my mission. And me and Dr. Greenberg spoke about this as well. And he said, if you want to take on that monster, go ahead. And I said, gladly. And slowly but surely, I hardly have any of my residents on sliding scales. The only people who may be on sliding scales are the newer admissions because they come with the sliding scale. But as long as I get in there within a few days, that sliding scale is gone.
Michael, can I ask a quick question on that?
Sure.
Tony, really, really great tips already. How was I kind of hear about this sometimes real and sometimes hypothetical fear among many team members that the nurses are going to be really upset if we try to take away patient sliding scale. Did you face that at all?
Yes, I did. About a month or two after I started, I remember a particular patient, I took away the sliding scale. And when I came back a few weeks later to reassess their blood sugar levels, the sliding scale came back. I said, I didn't order this. And I saw, my medical director's name on it. So we spoke, and he said, yeah, the nurse got a little frightened because the patient had a spike of 400 plus blood sugar, and they wanted that crutch of the sliding scale. So he gave them the okay. I said, yeah, we're not doing that. So I'm going to DC it again. And, a thing I do is when the discharge reason window pops up, I put in there, not evidence-based, let's, control the blood sugars with, scheduled medications instead of this crutch. So, yeah.
Tony, did it resolve, or
Oh,
did
yeah.
you end up back on the sliding scale again?
Oh, no, that sliding scale did not come back after I DC'd it the second time. So, yeah.
But did her hyperglycemia come more in line also?
Oh, yes, it did. I'm on these, patients' blood sugars like white on rice, and I'm constantly checking their trends and adjusting medications to make sure we have a nice, homeostasis,
Good.
and everyone's happy.
So that really is the key, isn't it? It's not the sliding scale becomes a crutch for not really optimizing the scheduled therapy, right?
Exactly.
Beautiful.
That's pretty much it. Yeah.
Beautiful. Thank you for that.
Mhm.
So, you told me a story once about how you would discontinue these meds, and your nurses would go around you to Dr. Greenberg and get them put back on. And, you know, I think we likened it to two parents where the kids are playing off the other one, right?
Oh, yes, for sure.
Did that happen in the beginning? And what did you do about it?
In the beginning, not so much to my face, maybe behind my back, but recently they've been very, you know, bold and to my face said, oh, well, you know, for example, this past week, the center ran out of Mylanta and she wanted a standing order for Pepto. And I said, no. I said, get some more Mylanta.
Right.
And she blatantly looked in my face and said, oh, I'll just go to Dr. Greenberg. It's like, oh, okay. So me and, you know, Dr. Greenberg and I discussed it, and I told him, I said, I felt like we're two parents, and I'm the evil parent that always says no, and he's the yes parent. And I'm like, no, we have to come to a consensus that they will respect the two of us.
And did they? And
Yes,
did that work for Dr. Greenberg?
Yes, he was cool with it. He's like, no, you're there, and you know, we agreed that I'm his extender. I'm an extension of him. When he's not here, I'm in the buildings 5 days a week. There's no reason for them to humbug him.
Right.
I'm here. Ask me the question. So yeah.
That's beautiful. Thank you.
No
Thank you,
problem.
Tony. And you know, to me, the pearl there is you work with your medical director, you get on the same page with the strategy, and some of these things that we're doing are hard and different for nursing. And the only way to break through that is to be on the same page. So you can be consistent and reinforce each other's message. Is that kind of what you're feeling, Tony?
Definitely. That's the general idea and the goal in mind.
Yes, yes. So that's the pearl for today. Good. That's one of the pearls. Good relationships between APPs and the medical directors, be on the same page and support each other. Awesome.
Yeah.
Thank you, Tony.
No problem. Thank you.
Teal, your center is in Care Haven, West Virginia.
Yeah.
How did you start to focus on deprescribing?
My approach is a little bit different than hers. So what I do is I call it a communications book. It's like a black binder, and the charge nurse knows, all three charge nurses, that every new admission they leave me a copy of the medication. So I just go through all the new admissions, and I then visit the patient and I see what I can get rid of, basically. And then for my long-term care residents, I do it a little bit differently. I have the medical records personnel print out once a month. Like, I make a note of my calendar, print out, and she prints out all the antipsychotic meds, and she prints out all the patients that are on more than 8 medications. Because I discussed with our pharmacist who comes in once a month, Nikki, I said, Nikki, what's the number? What's the target goal that I need to make to keep my patients off your list? And she gave me that number. And then another thing that I do that might help you, Tony, is the PRN medications. If someone needs something like Pepto or something, I'll order it, but I put a stop date on it that's less than 14 days. Because I talked to Nikki, our pharmacist, and she said that if it's less than 14 days or less, it doesn't get put on that list as one of their routine meds. So it doesn't get counted as one of those 8 medications. So it keeps the nurse happy because, you know, they get the medication for the patient that they need, but it keeps it automatically will drop off, and it keeps your numbers down.
Teal, that's beautiful. And that reinforces what we talked about with Tony, where PRN meds are necessary, but they need to not be there forever. And your strategy causes them to go away so that when they come back, the prescriber, be it yourself or your medical director, are aware that there's a problem again. And,
right. And I do that with my psych meds as well. Like, a lot of patients, you could prescribe them Ativan, but maybe it's just something happening at home or with their family. So I'll do the Ativan PRN for 2 weeks, and then it doesn't get on the antipsychotic list, and then the patient's better by then.
And you discontinue, and it's discontinued. That's great.
And I write them a referral to psych too.
When
So
you
that
told
someone's
me,
always following up.
well, that's a key, right? And that's a key for both Tony and Teal. It's just the consistent follow-up. One of the things I really appreciated about your story, Teal, was how you work with your consultant pharmacist who comes in, because we all have them. They come in once a month. If we're lucky, we get them a lot, but they come in at least once a month. And what do you do with them that helps you with deprescribing?
So I've worked there a long time, so I have a really good relationship with our pharmacist, and she goes through every chart and checks, and she makes what's called a med rec. But before she puts on paper the med rec, she comes to me and shows me all her med recs, and then we discuss and I talk to her, and almost half of the ones that she was going to report and put on paper, once I explain it to her, then it keeps it from getting on that report.
Let me tell you what I love about that as a pharmacist. Pharmacists love when they do work and it's recognized. But what you do is you make sure that when they make a recommendation, they are recommending in the dark. They don't see the patient every day. You do, and you're giving them the data and information that they wouldn't have had, that had they had it, they wouldn't have made the recommendation in the first place. That is often missing in our process. So that helps you with increasing your response rate, but it also helps you get rid of meds that are truly need to go away and can go away. Has that been your experience?
Yes.
Awesome. Well, listen, I want to thank Tony and Teal. And wait, Teal's Pearl is have a face-to-face with your consultant pharmacist once a month. They're there. How long does it take you to talk to them?
Not long at all, and I can also bill for it to the patient if I need to. Like if it's a long consultant, then I can bill, like say they don't need Tylenol anymore, then I can bill for pain and then put the Z code, the medication, under there. So you can still bill for the time.
This is beautiful. This is beautiful. So you're improving care, you're reducing meds, and you're billing, which is important also.
Michael,
So
this
yes,
is if I may just want to quickly highlight that very important point. I mean, personally, my life quality went so much up in my building when I started meeting with the consultant pharmacist. So anybody who is hearing today, to me, that is one of the golden tips provided today. Your acceptance of the recommendation will go higher once you hear from the pharmacy consultant live, because it's hard to decipher things sometimes through forms and all that. Your paperwork will go down, and your job satisfaction will go up, hands down, with the simple strategy of meeting with your pharmacy consultant. That just comes from my personal story, but I've talked to many physicians who actually do that, and some nurse practitioners who started doing it at Signature. So what an important tip that is.
Dr. Nazir, thank you so much for the reinforcement. And Teal and Tony, thank you so much for sharing your experiences. This was awesome. And thank you so much.
You're welcome.
So there is, may I just have a follow-up question?
Oh, sure.
Hi, everyone. There's a lot of interest in the chat, Teal, on the billing with the pharmacy discussion. Tell us a little bit more about which code you bill. And
it depends on how long the discussion takes. Like if there's one patient that takes up a long time with the pharmacist, then I would bill higher. But if it's not as long, then I just bill for whatever the medication is for. Say, like for instance, the Tylenol, I bill for pain, and then I put the Z code for the medication reconciliation to the patient, because I do educate the patient why I'm doing it under the pain code.
okay, thank you.
Well, I mean, the only thing I would recommend is that there's a lot of complexities around billing. We don't want this to be a billing session, but
No.
believe me, CMS wants us to do good care and do interprofessional care. So there are ways of getting this done. But again, please don't take it from us or this group. Just use this as an idea and go back to your compliance officer and all your billing experts and discuss it with them. But what Teal is shared is that there are ways to be thinking outside the box to get this done, because CMS does want us to provide good quality care. That's why they're giving us all these codes.
Right.
But what are the details? We don't want to kind of go into depth. This is not what this session is about. But really, the idea and the concept is very, very important that has been shared.
Excellent. Sabina, anything else in the chat before we move on?
Sabina, I see the last comment is very important. What do you think? Just a recognition.
I think, yeah, so Laura Finn says that there are many consultant pharmacists in the audience today. So thank you, team members, for attending and how much they appreciate working directly with the medical directors to reduce polypharmacy. I think that we've harped on that connection many times. And I think Teal and Tony just bring out, especially Teal today, brought out another very effective, I'm just efficient. I'm all about efficiencies. And it's much more efficient for me to talk to a pharmacist for 20 minutes than looking at a million recommendations that are not necessary and then chasing down my attending physicians to answer those recommendations. So I think meeting with a pharmacist and having shared goals and a strategy, love the strategy with the health information person printing out lists. I think lists can be very, very useful to approach medication classes. And I think you can get a lot done in a very short period of time. One way I like to save time with pharmacists, I'm all about saving time, is that they have really better information on how long a medication has been, whether it was ever DC'd, especially in psychotropics. That's really, really important and really, really helpful. So I think they have other databases than you and can really help you look at deprescribing and medications very efficiently. So you may spend a little bit extra time in that session, but in all the other subsequent work that you have, you may save a lot of time. So
beautiful. Thank you. Thank you. And listen, for everyone, remember when I opened, I said it's a 25% reduction on Teal's goal for all meds is 8. So she's going right after it. She's going large. That's a good number, and it helps keep her focused. So anyway, thank you both. And let's move on to the next piece of our agenda. And thank you for the questions and the feedback. I would like to introduce Dr. Mamata Yanamadala, who's going to speak to us today about Deprescribing Office Hours.
Hello, good afternoon. Thank you, Michael. My name was pronounced so accurately. I'm a geriatrician working at Duke University. I'm an assistant professor there, and I'm also the geriatrics fellowship director. And I'm so excited about being on this drive to deprescribing thing going on at AMDA. And thank you for including me in this. And I have had some experience with quality improvement for the past 10 years. I've designed several curricula in QI for interprofessional providers, mostly in long-term care, and led lots of quality improvement projects. And we are now taking an opportunity to think about deprescribing as a QI initiative where we are thinking about sustainable interventions. As you all know, it's quite challenging to think about deprescribing as medications do creep up. They come back up either because of the mom and dad phenomenon that Tony has discussed, or many other reasons when patients are going outside the facility and coming back. So how do we keep the intervention sustainable, and how do we even get going with this? These are some things that we could talk about. And I'm able to discuss some of these things with folks who are interested. There are some times that you could see on the slide here. I'll be available and you can sign up for a time slot. And I'm happy to meet with you all to discuss some strategies that you'd like to implement at your facilities. I don't think I can come up with anything more bright and beautiful than what Tony and Teal have discussed today. They have done lots of interesting things in their projects, and it's wonderful to hear from them how successful they were in their facilities. So I'll touch on some of those things today in the next few slides. Some of the formats that I suggest that have worked in the past when I have consulted with facilities on QI work is basically coming to these meetings with your team, medical providers, nursing, or pharmacies. I know pharmacy providers are not always available, but if they're available, that's an option and that might be helpful. And have an initial consultation. It could be either 30 minutes or 1 hour or 15 minutes. But what's important is to have follow-up appointments, and that might make it helpful for us to think about any hurdles that are coming across while you're trying to implement changes, and also think about sustainable interventions while we are following up during these meetings. The other way to think about it is within your corporations to have few facilities working on projects simultaneously so that they could learn from each other. And I'm happy to meet with 3 or 4 facilities in a meeting where everyone's able to share each other's work, just like how Tony and Teal did today. They had a chance to share so many strategies, and so many of us on this call had an opportunity to listen to their success stories and also figure out how we can implement some of those in our own facilities. Next slide.
Well,
so I'd like to say that the goals are to pick small interventions, just like how our speakers today did, right? They talked about working on a single patient, working on one patient where it was challenging to get somebody off of the sliding scale. But once you figure that process out, then you can apply similar things to other patients. How do you get it going on a single patient? And then avoiding the data trap. Sometimes it's very easy to get trapped in collecting a lot of data while we are trying to do implementation work. But we really don't need to collect much of data. We are trying to improve our processes. So that's the focus here. And also thinking about sustainable interventions. Once we discontinue the PRN medications or the sliding scale, making sure that they're not coming back up on the list. One of the great things that Teal has mentioned is how she's reviewing the admission MARs for the patients. And that's a great strategy to look at how medications are even coming into the facility. You stop it right at the beginning so that you're not having to deal with deprescribing at a later time. Next slide. I just included an example here, which I'm going to skim through really fast on some of the work that we've done in the past with some facilities, but like I said, it's not going to stand out too much after we have seen few examples with a couple of other facilities today. Next slide. We were trying to work on deprescribing anticholinergics. As you all know, that's this huge class of medications. It's all over the place, spreading across different groups of medications, and it's very challenging when we are thinking about this. And this particular facility didn't have any process for thinking about anticholinergic burden for patients. So how did we go around that? Next slide. We talked about reviewing one patient, starting with reviewing one patient, just like how Tony did. What are the meds that are causing anticholinergic burden? Then there's this huge list on this patient, and there are quite a few medications that could be contributing to the anticholinergic burden. What are the indications for these medications? Learning about that, and when were they started? Next slide. And you all know by the time you do this, it takes at least half an hour on a single patient. And if you're trying to review all 100 patients or 150 patients in your facilities, it's going to be a never-ending task. How do we get around this? Then folks brainstormed and they thought about, are there specific time points where we can ask these questions? Is it in the admission? Can we do an anticholinergic burden check? I think there's some noise that's coming. If folks could mute themselves, that would be helpful. Yes, somebody is mentioning in the chat that there's a webinar on reducing anticholinergic burden. That's a great resource, and we'll definitely take a look at it. So what are some time points where we can ask these questions during admission, during regulatory visits like Teal was doing? Can we chat with the pharmacist? Next slide. And then folks started to decide in this facility that they were going to start to think about the anticholinergic burden at the monthly review of medications, because they thought that would be more feasible rather than going through all the lists of medications for all the patients. And they had a chat with the pharmacist, possibility of adding the anticholinergic burden to the monthly review. And that's what happened. Next slide. The pharmacist started calculating the ACP and adding it to the monthly review recommendations. And it was easier for them to review things at that point because it was coming along with their monthly review, and it was coinciding with their problem list review also, and it made it easier for them to manage this. And then they also felt like maybe they could do some more focused review on individual medications such as Benadryl, as opposed to trying to do the entire anticholinergic meds. So this is also one thing that they came up with, where let's focus on one pill at a time and then get back to the other meds that are probably contributing to the burden. Next slide. So it goes on like this, where we just brainstorm each time and come up with different strategies that are more feasible, which are quite different for each facility. As you have seen, Tony had different set of things that she was doing, and Teal was doing different things in her facility. But we just have to meet and figure out what works best for your facility and how to do it in the most efficient manner. Next slide. Yeah, that's all I have. And please sign up. And I'm looking forward to working with you folks. Yes, Arif.
I think I heard something mistakenly. Can you clarify? I think you said it was a free session, right? That cannot be true.
It is a free session because I'm really passionate about quality improvement. And
wow.
The reason why I like doing this work is often quality improvement is taught in not in the right way, where we are using a lot of QI jargon. And more recently, I'm trying to engage folks with not having to use QI jargon, but trying to work with frontline providers to really work on improving processes that can improve their workflow. In fact, improve efficiency, just like how it has worked in Teal's case, where she talked about going and meeting with the pharmacist, reviewing these medication recommendations that the pharmacist is making on a monthly basis. If you have a chat with them, you're weeding out some of the recommendations that they're already making. For example, they might say, why aren't you stopping this anticoagulant? You have the discussion. That recommendation will not show up the next time. In month November, you have a chat. In month December, you only get 2 recommendations as opposed to 10 recommendations. So it improves your workflow. I think the shift in QI has to happen. I'm passionate about it, and that's why I want to be here, and thank you for including me here.
Wow, what a great opportunity. Believe me, there's going to be a few buildings from Signature who are going to be reaching out for sure, and I'm sure many others would want to do this. This is amazing. Thank you.
Thank you so much, Mamata. Yeah, we will be. And I like the idea of maybe a small group of facilities doing it together. I'll be looking at that for Avalon. Just from the chat, Fadi Haloub was mentioning that she has I hope it's Fadi, I got the right.
Dr. Chaloub is he.
I was just going to say, I hope I've got the right gender. Okay, Dr. Chaloub, would you mind unmuting yourself and give us a 2-minute rundown of your grand rounds approach?
I don't know if Dr. Chaloub has the ability to speak.
I am.
Yes,
oh,
there you go. There you are.
I was looking for the button.
Okay.
Yeah. In fact, I'm not a good speaker, but I'm just like briefly say what my experience was, is when the patient himself or herself, as you have a problem with the gender, are able to really make their point. I mean, some patients are really excited about the idea that to get rid of this medication, and this is when we start involving them with this decision, and it makes it much easier for everybody. So basically, that's briefly what my experience was with this.
So in your grand rounds, tell us about the grand rounds. What is that?
It's a great tool. I mean, in fact, Dr. Nazir, he's the one who was the main inciting to make those grand rounds. And I started like recently, in fact, and everybody got excited. Then from all perspectives, you got the nurse practitioner, the director of nursing, the nurse, and sometimes the LPN was involved also. So what happened is, like I'm talking about the recent grand rounds, is the nurse, like when the patient was complaining of anything, the nurse was on the spot fixing the problem. So while we were rounding, the nurse was also fixing all the problems. And the patients were so happy to see like 3-4 people coming at the same time, when they said, oh, nobody come to me to see me. You know, this grand rounds is really seriously is an amazing tool, and for fixing a lot of problems. And thank you, Dr. Nazir, again. This was your inspiration.
Oh, well, guys, let me be clear. I did not pay Dr. Chalhoub to say any of that.
Yes, you did.
Dr. Chalhoub is a very progressive, very, very interprofessional physician, and he runs with ideas very successfully, as you can see. So hearing that from you, Dr. Chalhoub, is just a great validation of anytime you bring a team together, as like we did on this D2D campaign, you're only going to win, right? I mean, patients love seeing teams providing care. So I think thank you for speaking out and validating that interprofessional approach does work in geriatrics. Thank you.
Let me show my face, maybe, so to reveal my gender.
Good to see you.
Okay.
Sabina, you're on mute. Sorry.
The gender reveal. I am so sorry, Doctor.
No worries, no worries. I have a beard.
Never
also.
again.
Yeah.
I'll buy you a drink at the next AMLA meeting if it's in person, I promise.
Okay.
So thank you for bringing this grand rounds up. We don't always have that opportunity, but I can tell you, when I've had the opportunity to round with a nurse and maybe another team member, I loved it. Again, ruthlessly efficient. You got so many things done, including hearing the patient's voice. So, so that's wonderful.
Dr. Kaplan, Dr. Kaplan, yeah.
Yeah,
so
I was just going to say this. Yeah.
Go ahead, Sabina. It was such a great idea. Just go ahead.
Well, Bob, thank you for putting this, Dr. Kaplan, putting this in the chat here. We are creating laminated cards to be posted at the nurses' stations, listing the most commonly used 15 to 20 meds with the highest anticholinergic burden scores. Wow, that is awesome. Bob, can I get you to send us that card so we can make it available to everyone via our landing page? I'd be just very interested to see that. So I think that's a wonderful idea. Are the nurses, Bob, are they nurses looking at these charts and doing what are they doing with those charts? Or what is your hope that they will be doing? Bob, and I know your gender, so I feel good.
Okay. So as far as sending, yes, this is all in the process of creation. This actually, I will take credit for this. This was actually, I don't have many good ideas, but this was one perhaps that will turn out to hopefully be a good idea. So this came up at our meeting just yesterday. And so the cards are in the process in consultation with our obviously consultant pharmacist to be created. And our in my building, we have our 2 unit managers are on our D2D team, very much engaged. And so we hope they're going to be obviously help lead this initiative and calling it to the attention of not only, of course, our attendings, but of obviously the NPs and PAs, any providers. I call them script writers who stop at the nurse's station, which obviously people do as they perform rounds.
Brilliant. That's great.
That's the
Yes,
definition
send us that intro once it's constructed, and again,
Yeah, we'll do that. No,
Yeah.
we'll do that.
yeah.
Rome
And
isn't
again,
built, as you know, Rome isn't built in a day, but we'll definitely do that.
okay, great.
It's a simple disruptive idea in an age of technology where we're looking for thousands and thousands worth of technology to improve care. Guys, simple things like grand rounding, talking to people live, and making simple lists to teach each other can also have an impact. So we don't have to wait for policymakers and startups and techs to come and save the world for us. We have so much under our power. And I think deprescribing and medication optimization lends itself so beautifully to interprofessional geriatrics, as you heard today already.
Anything else from the chat box for today?
I think that's all we have from the
Beautiful, beautiful. So we'll move on, and Dr. Von Price, do you want to speak about the Choosing Wisely champion?
Unmute, please. Unmute, please.
Sorry. Yes, thank you. I just wanted to remind everyone that nominations are open for the Choosing Wisely champions. That's for clinicians and team who've gone above and beyond to reduce unnecessary tests, treatments, and procedures. And I want to make you aware that AMDA has 10 Choosing Wisely statements. And by the way, here is the hyperlink to how to submit a champion. But next slide, there are 3 that. Can we get the next slide?
Yes, thank you.
There are, wait, no, there is no next slide. Well, anyways, we may not have the correct slide set, but I want to make you aware there are 3 medication related. One is insulin sliding scale, and I was made aware today that I'm the reigning Choosing Wisely champion, and I submitted my data last year and was chosen, and it was really a wonderful reinforcement for our team. And I think one of our nurse practitioner speakers could possibly submit her data to that regarding sliding scales to that nomination. The other one was statins in patients with limited life expectancy. And the third one on Choosing Wisely is blood not to treat frail older patients with antihypertensives unless it's above 150. So those are the 3 medication-related Choosing Wisely ideas or statements that you could submit your data and your experience to. I would highly encourage you.
I think Tony and Teal could be great candidates for this.
Right there.
Okay.
Yeah, so it doesn't always have to be, a huge number of facilities. Can be just your program. And again, just one experience of one facility teaches us all. And so we all win. So thank you for considering that. Next slide. And that's for Lori.
We just wanted to make everyone aware that AMDA membership has opened for 2022. So, Drive to Deprescribe is an awesome initiative, and it has brought so many people to AMDA that haven't participated in the past. So there's really no greater time to sign up than now. Benefits include free webinars. We have a new app with a members-only forum within it called AMDA Social. We have our journal, JAMDA and Caring for the Ages, which is our newspaper, along with discounts on educations and resources and more. We will hold an in-person annual conference this year in Baltimore, Maryland from March 10th through the 13th. I cannot wait to see everybody in person. We will also have a virtual option. And anybody who joins now will get a free e-version of our new pain management clinical practice guideline, with which Erin and her clinical team worked oh so hard on over the past year. For those of you who are a member of one of the other associations we have up here, ASAP, GAFNA, ALNA, APACN, or ACHCA, we have a joint membership offering that allows you really to join both associations at a reduced fee. So I have the link up on the page, and we encourage you all to join and hope that you'll get more involved with AMDA.
Great, great. Lori, thank you for that. So that you know, our next D2D webinar is on December 16th, and then our next progress update will be January 20th. Time is flying. Last thing I wanted to just let you know, there was a great article in JAMDA in November, delirium during acute events in nursing home patients. I urge you to take a look at that. It had great information where benzodiazepines as an independent risk factor for dementia was very, very interesting. So that's what we have today. And listen, we cannot thank you enough for spending this time for you. It is
Michael, quickly, can I just, sorry, quickly recruit speakers for our next session? So anybody who believes that they are doing a good job with this deprescribing and have had some good success, please reach out to us, because we will love to showcase your work so that others can benefit from it. Yes. We actually already have received a couple of requests this session, so we're really, really happy. But there's room for more of you to be presenting and teaching us. So please, please let us know if you want to be presenting. Just in a very relaxed environment, as you saw, Teal and Tony did a great job. So thank you.
Well, thank you all very much. Have a great night, and we'll see you in a month.
Bye-bye.
Bye-bye.